Okay. The outline, introduction, cardinal features, the classification of anesthetic drugs, the mechanism of action, the properties of an ideal anesthetic agent, the stages of anesthesia, the depths of anesthesia, the special features of the different intravenous anesthesias, and pre-anesthetic medications. These are what we're going to be looking at throughout our study today. So we begin with the introduction. General anesthesias are drugs that causes reversible loss of all sensation and consciousness. Please take note of reversible, very important. Now, what are the features? Now, features include, number one, sedation and reduction in anxiety. That's sedative hypnotics. We're going to learn that subsequently. Analgesia, they are going to remove pains. Suppression of undesired reflexes. General anesthesias are known to cause amnesia, that's memory loss, and skeletal muscle relaxation. So all of these are cardinal features that we need for a successful anesthetic environment. Now, what are classification of these drugs? They are classified as inhalational and intravenous. Inhalational group and intravenous group. Now, please take note for this for your theory exams. Now, for inhalational, we have gases. Nitric oxide stands out, N2O. And then volatile liquids, we have the likes of the halothane. We have the likes of the N-fluorine. We have the likes of the desflurane, the isoflurane. We also have the likes of the sevoflurane. And we have ether. Now, for intravenous, we can classify them as fast-acting or inducing drugs, inducing agents, or we can have slow-acting. Now, for fast-acting, we have the thiopental, we have the propofol, we have the etomidate. For slow-acting, we can have the opioid group, the dissociative group, and the benzodiazepine, or for short, BZD. Now, for opioid, fentanyl. For dissociative, kentamine. For BZD, the diazepine, the lorazepam. Now, mechanism of action, we begin. Now, a cross-section of the central nervous system stands out. And then you'll see the thalamus, the hippocampus. Thalamus has been indicated there. The hippocampus. Now, you'll see the reticular activating system throughout the brainstem. And then maybe other features like the cerebrum, the cerebral cortex, the spinal cord way below, and then behind you will see the cerebellum. Now, one mechanism of action, one theory holds that the cerebrum and the hippocampus have been known to be implicated in amnesia, that's for memory loss. Then the spinal cord has been implicated for immobility. You remember, for skeletal muscle relaxation, the cardinal features. Then the thalamus and reticular activating system for unconsciousness. Okay. Now, this is one way that we have been able to explain the mechanism of action. Now, another way we have been able to explain mechanism of action is that a neuron, pre or post-synaptic, now we have this receptor there, which is coupled with a channel, a ligand-gated channel. Now, GABA is an inhibitory neurotransmitter that acts on the GABA-A receptor. And once it binds, it causes influx of chlorine, which causes hyperpolarization. And by so doing, there is a fall in neuronal transmission, causing anesthesia. Now, another way, again, similar to GABA, another inhibitory neurotransmitter, glycine, it works similar as GABA. causing hyperpolarization. So some different anesthesia work by this method. A fourth mechanism of action also is that some other drugs act on the NMDA receptor, that's N-methyl D-aspartate receptor, and once that is blocked by these anesthesias, like the like of nitric oxide and ketamine, glutamate cannot bind there, and glutamate is an excitatory. So as glutamate cannot bind there, their action is halted. Now the last one, although not so common anyway, is the one that blocks the cation channel, which is coupled to a nicotine cholinergic receptor. Cholinergic receptor. So if that is blocked, neurotransmitter cannot bind, and then eventually cation cannot enter or leave. This mediates analgesia or amnesia effect. Now we're going to be looking at properties of an ideal anesthesia on the patient. That it should be pleasant, it should not be irritating, it should be one that should have no cause for nausea or vomiting, either pre or post-operative. Okay. Now also, we must realize that it should be a drug that induction and recovery should be very fast and without after effect. Yes. So that's that for an ideal anesthesia. So when we are choosing an anesthesia, for those that might specialize in anesthesia and as an anesthetist, you realize that these are things you must consider. For the surgeon, it should have adequate analgesia so that the patient should not feel pain while the surgery is being taken. The patient should be immobile with skeletal muscle relaxation very well, so that muscles do not become rigid or muscles do not contract in the event of the surgery. It should not be inflammable or explosive. Okay, these are drugs that, because we are going to be dealing with fire. There are some fire cutting instruments in the theater. For the anesthetist, it should be easy to be controlled, so that in fluctuating blood pressures, the anesthetist should be able to control. They should be versatile, can be found everywhere. Okay, easy to be gotten. It should have rapid depth adjustment, still trying to emphasize the first point. It should be cheap, should be stable. It should be potent, so that even at low concentration, it can be able to do what it is required for. That means if it's an inducer, should be able to induce anesthesia even within 30 to 40 seconds, like the likes of propofol and the like. Okay, now we're going to be looking at the different stages. Now, from administration to loss of consciousness, I call that stage 1. From loss of consciousness to onset of regular breathing 2, then to cessation of breathing 3, and then to failure of circulation and death 4. And then you see that now they have some special names. 1 can also be called analgesia, 2 delirium, 3 surgical anesthesia, and then 4 medullary paralysis. Now, what are characteristics? For 1, loss of pain sensation. Now, but reflexes are still normal. Reflexes and respiration are still normal. For 2, excitement. There's rise in blood pressure, heart rate, cardiac output due to sympathetic nervous system. Then this is inconspicuous anyway in modern medicine. Now, stage 3 is ideal for surgery. There's loss of muscle tone and reflexes. And then stage 4, there is severe medullary depression, respiratory depression also. And then muscles become flabby. Pupils are also going to dilate, and then there's low blood pressure. And ventilation and circulation should be very monitored, because death could be very imminent if not careful. Now, what are the different depths? The depths include induction, maintenance, and recovery. Now, induction, from the time of administration to loss of consciousness. Maintenance, giving a steady state, and then recovery, the patient regains consciousness. So for induction, we're going to be talking about what are some drugs we can think about, and then what are some things to take note of. For induction, in the adults, we could administer the IV, intravenous agent, and a good example of intravenous agent is propofol, whose action begins within 10 to 30 seconds, very, very fast. Okay. Now, in children, because IV access is somehow way difficult to get, we could use sevoflurane. Please take note of this difference for objective MCQ questions. Now, also please note that neuromuscular blockades like the rancorium, the antracurium, and a whole lot of them can also be used to facilitate tracheal intubation. Remember, they are going to cause muscle relaxation. So it's something to also take note for the case of MCQ questions, okay? So that's a synergistic example. Then for maintenance, we should be able to monitor vital signs, okay, to see is it rising, is it falling, and we should also check the patient's response to stimuli. Then for recovery, this is when the drug leaves the site of action and then into normal circulation. Okay. Now we should also use recovery drugs here, such drugs like the neostigmine if we used neuromuscular blockades. Now we are going to be talking about some specific examples of intravenous. So we begin with barbiturates, e.g. thiopental. It's an ultra short acting. It's no longer in use anyway. Please take note. It has been replaced with another, which I'll tell you soon. It is a potent anesthetic but weak analgesia. Very important. It causes low blood pressure, causes a fall in intracranial pressure and reflex tachycardia. Now watch the substitute. Now the substitute is propofol. Propofol has replaced barbiturate, the thiopental. Please take note for MCQ. Now, what other things? It is a good inducer, and it does this within 30 to 40 seconds. Okay. Now, it is poorly water soluble and it comes as an emulsion. Now, propofol is a CNS depressant. Propofol also causes yawning and hiccup. Propofol muscle twitching. Propofol also causes a fall in blood pressure and has no analgesic effect. Now, antiemetic effect helps in postoperative control of nausea and vomiting. Okay. Now we go to kentamine. This is a dissociative agent. Now, kentamine has been related pharmacologically to another hallucinogen drug called phenylcyclidine. Very important for MCQ, please. Okay. Then there's a triad, although something in the center, which is light sleep. Now, what do we see as cardinal things for kentamine? It causes analgesia, causes immobility, it causes amnesia, that's memory loss. Now, it is a good bronchodilator, so it's fine useful in asthmatic patients. Kentamine also causes cardiac output, blood pressure, and heart rate to increase due to sympathetic effect. So it is contraindicated for people with congestive cardiac failure and hypertension. Okay. It has been abused. Okay, when mixed in drinks, it causes the whole triad that we just mentioned: light sleep, amnesia, and immobility. So it has been used in rape. Okay, it has very been abused. Now it is a dissociative, like I said, in classification, and even when we started talking about it. Now benzodiazepine and then opioids, we'll look at it side by side. For opioids, it has been administered intrathecal, epidural, and intravenous IV. Okay, a good example here is fentanyl. And opioids has been seen that they have the following characteristics: that they are poor amnetics. Okay, they are respiratory depressants. They are going to depress the respiratory system, the respiratory center in the medulla. They cause hypertension, they cause nausea, they cause vomiting. They have been also to note that it is also noteworthy that you can reverse opioid poisoning or opioid excess, or when recovery does not ensue fast, you give naloxone. Now for benzodiazepine, a good example, diazepam, it is used alongside other general anesthesias. Okay. Now, benzodiazepine has also been noted to cause minimal CVS defect, and they have also been noted to do respiratory depression. And benzodiazepine, they have also been noted to do temporary anterograde amnesia. We're going to discuss opioids and benzodiazepine in detail in subsequent lecture. Now, the last but one, etomidate. Etomidate is an hypnotic and induces anesthesia and lacks analgesic property. It inhibits 11-beta hydroxylase. This enzyme is very important. Okay. Then we go now to pre-anesthetic medication. I think as we round up here, examples of drugs that we use before we give anesthetic agents: antacids, anticholinergics, antiemetics, benzodiazepine. We also give the opioids. We also give the antihistamine. Now, antacids, especially the H2 receptor blockers. Now, a good example here is cimetidine, ranitidine. These drugs are very important because they are going to prevent the secretion of HCl. Now, for anticholinergics, we give these ones to prevent bradycardia. Remember what cholinergic drugs can do. So, we have to give them to prevent bradycardia and even secretion of fluids from saliva to GI fluids and what have you. Okay. Then we also have antiemetics to prevent nausea and vomiting, post-operative in particular actually. Benzodiazepam to relieve anxiety, opioids for pain relief, that's to provide analgesia, and then antihistamine for allergics, so to prevent allergic reactions. Okay.